Hello, welcome, and thank you for listening to my presentation on intranasal delivery of COVID-19 mRNA vaccines. So here's a rundown of what will be covered in this presentation. I'll go over things like the pathogenesis of SARS-CoV-2, the mRNA vaccine methods of action, the flaws of current parenteral or intramuscular delivery systems, the intranasal application of it and the challenges associated with these mRNA vaccines, the improvements made to delivery vehicles, the immune response, factors like dosing consistency and patient-to-patient variations, and of course regulatory aspects as well, and followed up by conclusions. So here's the pathogenesis of COVID-19 caused by the SARS-CoV-2 virus. The infection begins when the virus enters human cells by binding to the ACE2 receptors. These receptors are primarily found on epithelial cells in the lungs, which is why respiratory symptoms are so prominent. Once inside the body, the innate immune system is the first to respond, triggering an inflammation response in an attempt to fight off the virus. However, in many cases, this early response is not strong or quick enough to stop the viral replication, then allowing the virus to spread deeper into the respiratory tract. As the infection progresses, the adaptive immune system kicks in, and this includes the activation of T cells, which help to destroy the infected cells, as well as B cells, which produce antibodies. These antibodies are designed to neutralize the virus and prevent it from infecting more cells throughout the body. Unfortunately, however, in some patients, the immune response has become overactive, which leads to a dangerous condition known as cytokine storm. And this is where excessive inflammation causes significant damage to the lung tissue and other organs, and high viral loads of inflammation in the lungs impair their normal function, often leading to complications such as pneumonia, low oxygen levels, and in severe cases, respiratory failure. And understanding this progression could help us appreciate why early intervention and targeted therapies are so crucial in treating COVID-19. The mechanism of action behind the COVID-19 mRNA vaccine is both innovative and highly targeted. These vaccines were specifically designed to deliver genetic instructions in the format of messenger RNA that code for the SARS-CoV-2 spike glycoprotein. This is the key protein the virus uses to enter human cells, and it's also the main target of our immune defenses. Once the mRNA is injected, it enters our cytoplasm of our cells. Here, the ribosomes can translate this mRNA and produce copies of the spike protein. Importantly, the spike protein is harmless on its own, but the immune system quickly recognizes it as a foreign invader. This will trigger an immune response where antibodies are produced to neutralize the spike protein, and CD8 plus cytotoxic T cells are activated to help destroy any infected cells. And most importantly, after vaccination, the immune system forms a memory of the spike protein. So if the body does encounter the actual virus later on, it can respond much faster and more efficiently, either preventing infection or significantly reducing the severity of illness. While intramuscular mRNA vaccines, such as those delivered using lipid nanoparticles, have been incredibly effective in protecting against severe COVID-19, they do come with several key limitations. First, these vaccines are excellent at producing a systemic immune response, meaning they help the body defend against illness throughout the bloodstream and internal organs. However, they do not trigger a strong mucosal immune response, which is the type of immunity needed at the surface of the nasal and respiratory tract. That's important since SARS-CoV-2 primarily enters through the nose and the upper airway, where it can be replicated and spread before the systemic immune defenses are fully activated. This means that while the vaccine may reduce the severity of illness, it might not prevent the initial infection or viral shedding, especially in the nasal passages. Another practical concern is needle phobia. Recently, in a global study of over 2,000 participants, more than 63% reported some degree of fear or aversion to needles. This fear can be a real barrier when it comes to vaccine uptake, especially when multiple doses are required. These limitations highlight the need for alternative vaccine delivery methods, such as intranasal vaccines, and that could better target the site of infection and improve public's acceptance. Shifting from traditional injectable vaccines to intranasal mRNA delivery presents some significant challenges, both biologically and logistically. One of the biggest obstacles in the mucosal barrier itself. The nasal cavity is protected by mucus, cilia, and enzymes like RNases, all of which are designed to trap and break down foreign particles, including mRNA. So, for the vaccine to be effective, it must reach the nasal epithelial cells before it's degraded. Another issue with LNP formulations is that they are effective for intramuscular delivery, but they can get trapped in the nasal mucus and are quickly cleared from the nasal cavity. This short residence time can significantly reduce absorption and immune response. There are also behavioral factors. For instance, if a patient were to blow their nose right after administration, it may remove much of the vaccine before it's had a chance to be absorbed. And finally, regulatory challenges are also a major hurdle. New vaccine delivery methods like nasal sprays require extensive validation and safety testing before they can be approved, and this will slow down the development and rollouts. These limitations need to be addressed for intranasal mRNA vaccines to become a practical and effective option. When it comes to developing effective intranasal mRNA vaccines, the choice of delivery vehicle is critical. These systems need to protect the fragile mRNA and enhance its absorption through the nasal mucosa and stimulate a strong immune response. So first we have chitosan-based nanoparticles. Chitosan is mucoadhesive, meaning it sticks to the nasal lining. This increases the residence time of the vaccine and boosts antigen uptake. It also supports a dual immune response, both mucosal IgA and systemic IgG. Next, the cyclodextrin modified PEI or CPPEI system is designed to open tight junctions in the nasal epithelium, and this allows for better penetration of the vaccine. It also safely and effectively delivers mRNA without causing significant toxicity. As we previously mentioned, LNPs are well known for the injectable mRNA vaccines. However, when modified with chitosan or mannose, they become more effective intranasally. These modifications help with mucosal targeting and protect the mRNA and improve uptake by immune cells. And lastly, nanoemulsions, which are oil and water emulsions, have particle sizes under 200 nanometers, and this small size helps them cross the mucosal barriers, and they're great at protecting antigens from degradation while enhancing the mucosal adhesion and immune activation. Together, these delivery platforms offer promising solutions to improve the efficiency and effectiveness of intranasal mRNA COVID-19 vaccines. To enhance the immune response of intranasal mRNA COVID-19 vaccines, researchers are exploring a combination of delivery systems and adjuvants to optimize vaccination regimens. One strategy involves using modified LNPs that are coated with chitosan functionalized with mannose. This design specifically targets dendritic cells, which are key antigen-presenting cells. The chitosan also improves mucosal adhesion, as we mentioned before, helping the vaccine stay in the nasal cavity longer, while mannose boosts antigen presentation, increasing immune activation. Next, the LPGMP adjuvant is a combination of lipopeptide and STING agonist and is used to further boost immunity. This adjuvant enhances T cell activation and promotes IgA secretion and supports the development of tissue-resident memory T cells in the respiratory tract, which is an important defense against reinfection. And finally, heterologous prime boost regimens are proving to be highly effective, where this approach involves the initial parenteral or injectable priming followed by an intranasal booster, resulting in dual layered immune defense. And this will provide strong systemic IgG antibodies and local mucosal IgA immunity in the nasal tract, creating a more robust and localized immune response, which is crucial for preventing both infection and transmission. So, when developing these intranasal COVID mRNA vaccines, several patient aspects must be addressed. They need to know how to measure it, so a metered dosing system or a unit dose system with a nasal spray or inhaler would be helpful. Using thermoresponsive gels could help improve the retention of the therapeutic drug. Regulatory bodies like the FDA and EMA will carefully evaluate local safety concerns, and this includes the potential for nasal irritation, inflammation, or risks of unintended biodistribution. And finally, for intranasal vaccines to move beyond lab scale development, industrial scale manufacturing must meet stringent validation and quality control standards, ensuring that both the product and say is safe and effective for large scale distribution. And just for a few closing remarks before we get into the references pages, the intranasal application does have some promise, especially if we develop the adjuvants or the delivery vehicles to get the mRNA to its targeted destination. It does seem to work very well used alongside like a booster with an intramuscular application, but of course, further developments could probably have it as a standalone as well. But that would require more validation, more time, more money, more research, just as everything else would. And here we have the first reference page, the second reference page, and lastly, I'd like to thank you for listening to my presentation.